Good afternoon. At the very onset, I would like to thank Dr. Umesh Khanna and his organizing team for giving me this opportunity to talk about, in this unique meeting about case-based discussion in renal diseases. I have been tasked to talk about drugs in the kidney, and I will talk about a very common group of drugs which is often used irrationally, that is proton pump inhibitors and its effect in the kidneys. I start with my case. This is Mr. RG, a 55-year-old gentleman who is a type 2 diabetic and hypertensive with controlled sugars, asymptomatic except for occasional epigastric discomfort. He is on vildagliptin, metformin, rosuvastatin, amlodipine, and pantoprazole. His blood sugars and blood pressures are well controlled. A couple of months back, he developed COVID-19 infection, was admitted and treated with steroids, and his regular medications were continued. Because of the use of steroids, his pantoprazole was increased to 40 milligrams twice a day. He was discharged after 7 days with tapering doses of steroids and his regular medications. Came back to us last month with symptoms of upper respiratory tract infection and headache. His MRI showed rhinoorbital mucormycosis, and he was started on amphotericin and steroids. Where it stopped. 7 days after his therapy, he developed worsening creatinine and he had persistent hypomagnesemia and hypokalemia. His renal failure, low magnesium and low potassium was attributed to amphotericin B. As the creatinine was progressively increasing, it had gone up to about 4.3 milligrams per deciliter. Amphotericin was withdrawn and posaconazole was added. Creatinine still did not reach the normal baseline after 1 week. And this is when the patient was counseled and he underwent a renal biopsy. The renal biopsy showed actually essentially normal glomeruli, but there was a lot of infiltration in the interstitial. On a high power, you can appreciate there was lots of leukocyte infiltrate in the interstitium of the kidney. And there were many eosinophils which could be appreciated in the infiltrates. The electron microscopy showed extensive backwardation of the proximal tubular cells. A diagnosis of acute interstitial nephritis was made along with acute tubular injury. The probable cause was considered to be drugs and his medication list was reviewed. Pantoprazole was considered a possible suspect, which was withdrawn. Then over a week, the renal functions were normalized and again he was restarted with amphotericin. Currently has normal renal functions. His hypomagnesemia and hypokalemia is even easier to correct now. A recent radiological evaluation showed that his mucormycosis is stable and has not progressed. This case actually illustrates many issues with proton pump inhibitors. We often use them for long periods and they are very soft indications of initiating therapy. Therapy is usually continued when it is not required. We rarely de-prescribe these medicines, often as part of a co-prescription, as in our case with many drugs during the COVID infection along with steroids. These drugs, as we have come to know, has multiple side effects and renal adverse effects are actually not uncommon. As we know, proton pump inhibitors are a group of drugs which turns off the proton pump and reduces acid production by the proton pumps in the stomach. The commonly used proton pump inhibitors are omeprazole, lansoprazole, pantoprazole, esomeprazole, and rabeprazole. They are commonly used in peptic ulcer disease, Helicobacter pylori eradication therapy, and patients with gastroesophageal reflux and dysphagia. It's important to know that gastric acid is important for breakdown of food and release of micronutrients. And they interfere with the absorption of iron, vitamin B12, calcium, and magnesium. The proton pump inhibitor market is huge and it is now maximal growth is seen in our part of the world in South and Central Asia and Australia. It's a $3.24 billion industry with a 4% growth every year. The maximum growth is in North America, but our part of the world also the growth is substantial. Now we know there are multiple adverse effects of proton pump inhibitors. As discussed, it reduces the levels of B12, magnesium, iron, increases the risk of fractures, causes dementia, increases Clostridium difficile infection, and there are various cancers being associated with proton pump inhibitors. And there are studies, not documented though, that it can worsen cardiac events. For a nephrologist, we have now come to appreciate that use of proton pump inhibitors actually has significant risk of progression to chronic kidney disease. Chronic uses leads to various forms of cancer like esophageal cancer, gastric cancer, human carcinoids, and colon cancer, leads to increased risk of bone fracture, can cause encephalopathy and dementia, and also there is an increased risk of cardiovascular events. But for a nephrologist, this is the most important component, the development of progressive chronic kidney disease. I'll spend a few minutes with nephrotoxicity of proton pump inhibitors. There's a high risk, almost 1.5 to 2 times, of developing acute kidney injury on long-term use of proton pump inhibitors. This is usually an allergic reaction, not dose-related though, and can happen anytime, but common if they are being used for a long period of time. Happens in young people because the immune system of the younger generation people are actually more robust. The acute kidney injury is often associated with the development of chronic kidney disease. Association is more pronounced when the patient is taking higher doses of PPI. Twice daily dosing increases the risk by 15% than a person who is taking a single dose of proton pump inhibitors. The risk is more than the use of H2 receptor antagonist. The progression in this group of patients is because of interstitial fibrosis and endothelial dysfunction. So a proton pump inhibitor actually leads to the deposition of the drug itself or its metabolites into the tubular interstitium, leads to an immune reaction. This immune reaction leads to an interstitial inflammatory infiltrate and edema, as was seen in our patient's biopsy, leads to an florid acute interstitial nephritis, causing acute kidney injury. And this acute interstitial nephritis is progressive, leading to interstitial fibrosis and tubular atrophy. Acute kidney injury progresses chronic kidney disease, and then it leads to an irreversible decline of kidney function, leading to end-stage renal disease. The co-prescription of proton pump inhibitors sometimes worsens the kidney outcome. Not just it worsens bone fractures, GI malignancies, and other diseases, but the kidney disease is actually very common. Almost, if you use proton pump inhibitors with NSAIDs, the risk of developing a kidney disease, a progressive kidney disease, is almost 20%. So how long should we be using proton pump inhibitors? So whenever a patient comes with you with a prescription of proton pump inhibitors, look and find out whether there is really an indication of PPI use. If not, stop it. Or if the indication is nebulous or ambiguous, then you can lower the dose and stop, or tell the patient that they can use this on demand, like a PRN prescription. If a patient has mild to moderate esophagitis and has been treated for 4 to 8 weeks, again lower the dose and make a SOS prescription. A patient who has been treated for definite indications like peptic ulcer for 12 weeks, and the patient is asymptomatic following treatment, was used for an ICU stress ulcer prophylaxis and is out of the ICU, or there is only just an asymptomatic H. pylori which you have treated for 2 weeks, stop the PPI. In all these situations where you have stopped or reduced the dose, look for recurrence of symptoms and rebound hypersecretion of the gastric acid. Patients who have severe esophagitis, Barrett's esophagus, bleeding because of gastrointestinal ulcers, or are chronic NSAID users with a high risk of bleeding, you can continue the drugs, but closely monitor the adverse events. And if the adverse events are quite severe, you should deprescribe the drug with a consultation with a gastroenterologist. In the renal context, the use of PPIs should be used very rationally. And even when you are going to start a new prescription, you should look for a clear indication, look for the dose, and you should be sure as to how long are you going to use it and what is the goal that you're going to achieve with these drugs. Not to renew a prescription which is continuing if there is no documented indication. And if you have to continue the prescription, monitor the renal functions. 6 monthly to yearly estimation of GFR. If the patients are with CKD or have increased risk of chronic kidney disease, like our patient with diabetes. Magnesium levels should be started at the initiation of therapy, and it should be monitored more frequently if the patient is on drugs which can cause hypomagnesemia, in our case, Amphotericin and or diuretics, which are commonly used, as Dr. Bhaumik talked about it. And in patients where you're using digoxin, because you may develop arrhythmias because of hypomagnesemia. If the patient develops renal adverse events, we should have strategies to cut down or mitigate these effects. We should always replace magnesium because hypomagnesemia causes endothelial dysfunction and leads to progression of chronic kidney disease. If the patient develops acute interstitial nephritis or chronic kidney disease, preferable to discontinue the PPIs. And we should all know that if you re-challenge or write the prescription again, you can lead to recurrence of the kidney disease again. We should, if you are forced to use PPIs, think of alternative to PPIs like the H2 receptor antagonists. Should look for the triggers which causes this epigastric discomfort or acid secretion. Should always advise for weight loss, and we should tell patients to avoid meals 2 to 3 hours within bedtime. So ladies and gentlemen, I would like to summarize and conclude my talk with this excellent editorial in European Medical Journal, where the authors say that we should be increasing the awareness for both in-hospital doctors like us and both primary care doctors to promote the judicious use of proton pump inhibitors. And we should curb over prescription and hence reduce the risk of developing adverse effects. They are a useful group of drugs, but like all drugs should be used appropriately and prolonged usage should be discouraged. And we should always look the benefit and the risk ratio when we prescribe PPIs. And we need to do trials in our settings also to look for association between PPI and adverse outcomes by rigorously designed trials. Thank you very much for your kind attention.